This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker this evening, we'd like to give an overview of our free program to those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speaker this evening, Dr. Holly Gilmer, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter Deanna, who's also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 ED&F conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started just 100 groups this last week. We've started our 100th group. And each group is given free web pages with a link to the directory and map. We receive feedback. The conference provides valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Daylight Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for future replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for the program, and it usually covers our monthly web fees. Please visit our store and check out the helpful products that we offer. So just a general disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment. I think we may have lost some audio, so I'm going to go over the next webinar.
I'm back. And our next webinar is on March 15th, and it is about silver ring splints for Ehlers-Danlos fingers and thumbs by the Silver Ring Splint Company and occupational therapist. Other upcoming webinars include April 5th, Dr. Neil Schechter will present chronic pain in pediatrics. And on April 19th, Dr. Ann Maitland returns for the second time, and she will present mast cell activation syndrome in EDS, second part, so don't miss that. That was a very popular webinar for the first part, and you can check that on our website if you'd like to review that. All upcoming speakers will be posted on the webinars page on our website, so see that for the full schedule. For those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. You will only see your own questions, not those of other attendees. So it's my pleasure to introduce Dr. Holly Gilmer, Her topic tonight is Chiari and EDS. She's a pediatric neurosurgeon at the Michigan Head and Spine Institute and the chief of pediatric neurosurgery at Beaumont Hospitals in the Detroit, Michigan area. She is also an associate professor of neurosurgery at Oakland University School of Medicine in Rochester, Michigan. She specializes in adult and pediatric Chiari malformation, decompression, and peripheral nerve surgery. She has special interest in hydrocephalus, tethered cord, neuro-oncology, and craniofacial reconstruction, and has certifications in neurological surgery and pediatric neurological surgery. Dr. Gilmer has received the Our Detroit Top Doctors Award for a decade, from 2004 all the way to 2014, and it's my pleasure at this time to go ahead and introduce her. We're going to load her slides. And Dr. Gilmer, I'm going to go ahead and turn over the microphone to you.
Thank you very much, Deanna. Thank you for the honor of having me speak today.
We appreciate it.
So we're going to talk about Chiari 1 malformation and Ehlers-Danlos syndrome. As a lot of you know, the Chiari malformations are types 1 through 4, but we really see Ehlers-Danlos with Chiari 1 malformation. Deanna, I'm not seeing my arrows at the top.
Okay, I think we need to adjust your presenter status if we can.
Okay.
Let me just take a moment. John, can you add her as a presenter? There we go. You should be all set. You seen the arrows show up?
Not yet.
Okay, she may be logged in twice. We may need to grab a different, her name on a different line, perhaps. Okay, sorry about the delay. He's working on that. There we go. And I think your screen will refresh and you should see those in just a moment.
Okay.
Okay. Are you okay now? Can you see them?
It seems to be loading.
Okay.
I can move your slides for a minute until that refreshes. So I'm gonna. Are you ready?
Sure, but my slides are not showing to me.
Is there another screen that you have up, a duplicate screen? Because I do see you logged in twice, so you might have another window on your computer that's connected.
I'm going to minimize this for a moment. Yes. Okay, so then I should close the one that is still loading. Okay, I'm going to get out of that.
Yes.
All right.
Okay.
Great.
Okay.
Super. Good. We're all set. So Chiari 1 malformation, for those who are not as familiar with it, is related to basically the back of the head or the posterior fossa being too small, what we call posterior fossa hypoplasia. And that causes obstruction to flow of fluid at the foramen magnum, which is here. So in this patient, and this is really more of a Chiari 1.5, because part of the brainstem is actually down into the spinal cord. But you see the cerebellar tonsils here going down into the spine. This is the bottom of the skull, or the foramen magnum. So none of the brain should be below this line, and you have this additional tissue, cerebellar tonsillar tissue, going down into the spine, actually all the way to C2 in this patient. When that happens, it acts as a cork in a hole and basically plugs the flow of fluid between the brain and the spine. which causes a buildup of fluid and pressure in the brain. The additional tissue here in this hole, which is only meant to admit the brainstem and spinal cord, causes pressure on the brainstem, and that leads to our brainstem findings, cranial nerve findings. This patient also has a syrinx, which we can see in Chiari 1. It occurs about 1 in 1,000 live births. And if you have a first-degree relative with Chiari, then you have about a 1 in 10 chance of having Chiari. So it can be a hereditary problem, but not always. Just as comparison, normal to abnormal, in this picture from Mayfield Clinic, all of the brain, all of the cerebellum is above the foramen magnum as it's supposed to be, but in patients with Chiari 1, the cerebellar tonsils, which are essentially the bottom of the cerebellum, are down into the spinal canal, causing the problems that I just detailed. Generally speaking, in understanding why this is a problem, because we have obstruction of CSF flow at the foramen magnum, but we can also have problems with absorption of fluid. The CSF, cerebrospinal fluid, circulates in the brain and the spine, is normally absorbed into the dural venous sinuses, which are essentially large veins that run between the dura and the skull. When the skull is too small in this area, the venous drainage is constricted, you have higher venous pressure within those spaces, so there's decreased ability of the CSF to absorb. So Chiari is actually an absorptive problem and an obstructive problem. And if you think of it that way, then you can understand why patients with Chiari malformation can have other problems like headaches, pain behind the eyes, a feeling of pressure behind the eyes, pressure in the ears, seizures, and other issues just related to global constriction and buildup of pressure. So other problems associated with Chiari 1 malformation, seizures. One doesn't directly cause the other, but there is a higher incidence of seizures in patients with Chiari. Autism spectrum, craniosynostosis, which is actually fusion of the normal sutures of the skull. So in these children, the skull forms too small globally, which also about 3 to 5% of those patients will also have a Chiari malformation. Migraine headaches, vascular headaches related to problems with venous drainage and circulation in the brain. Pseudotumor cerebri, abnormal buildup of fluid in the brain, which is actually related to abnormal venous drainage and absorption. Ehlers-Danlos syndrome, which we're going to focus on today. Tethered cord Klippel-Feil, which is a fusion of cervical vertebrae, and myelomeningocele, that's Chiari 2. So generally, what is Ehlers-Danlos syndrome? This I'm sure most of you are familiar with, but we'll just go over it briefly. 6 types. Before 1997, there were actually more than 10 types of connective tissue disorders, which were described as, loosely hereditary disorders of connective tissue. In 1997, these were condensed into 6 types, which are the classic type, involving joint hypermobility, elasticity of the skin, easy bruising, type 3, hypermobility, which also involves recurrent joint dislocations. Vascular type, this is probably the most dangerous, in which patients can have sudden ruptures of blood vessels, large arteries, aortic ruptures, organs within the body. Pregnant women with vascular type EDS can have uterine rupture, for example. And then the kyphoscoliotic, related to severe scoliosis. And then types 5 and 6, arthrochalasia, and dermatosparaxis. The first 4 types are autosomal dominant inheritance, meaning that if you have one parent with EDS, you have at least a 50 to 75% chance of having it. There's never 100% inheritance, but the gene is dominant. If the last 2 are autosomal recessive, so you have closer to a 25 to 50% chance of having it or being a carrier. All of these genes have been identified as directly causing each type of EDS. The unifying characteristic of all 6 types is the hypermobility. Everyone with EDS doesn't have the elastic skin, even though, we're familiar with that. And the other types have different, additional characteristics, but all of them have the joint hypermobility. This is a nice schematic, actually, from the EDS Awareness website, just breaking down major and minor diagnostic criteria for each type. So the skin elasticity that you can see. Now, this is not my patient. I have not been practicing for this long, but I have seen patients demonstrate this elasticity of the facial skin and at the neck. The rest of these are my patients that I've seen in the office. These 2 demonstrating the joint hypermobility and the elasticity of the skin, which may be actually anywhere on the body. All of these, we sort of wince when we see this, but actually these maneuvers don't hurt the patient. So that's something else. They just sort of pull the skin out, they pull the joints back. It is painful in terms of the actual joints. They can have joint pain, and that's kind of typical of EDS. But demonstrating the hypermobility is just kind of routine. And that, I think, makes the diagnosis a little more difficult, because a lot of the time the patients grow up, I'm pretty flexible, but they don't necessarily think it's unusual. This is another way to look at EDS, Baton score, and Brighton criteria. Now, diagnosis of EDS is by a geneticist who will do genetic testing looking for the specific genes. But Baton score and Brighton criteria will also be used when they're evaluating you. They will ask a lot of questions, clinical questions, as well as doing the genetic testing. Essentially, if you have 4 out of 9, a score of 4 out of 9 in terms of hypermobility, as well as a relative, a first-degree relative with EDS or any of the minor criteria, then you loosely qualify as Ehlers-Danlos, although you really should be definitely diagnosed by a geneticist. It's also important to be evaluated because there are other connective tissue disorders that mimic EDS, Marfan, cutis laxa, Loos-Dietz, osteogenesis imperfecta, Larsen, Stickler syndrome, arterial tortuosity, to name a few. So what do we see with the patients with Chiari malformation? The most common symptom is headache, and it tends to be occipital or suboccipital, worsened by any kind of Valsalva maneuvers like coughing, sneezing, laughing, bending over, stooping down. There's neck pain, back pain, dizziness, a feeling of spinning or vertigo. A lot of the time the patients have ringing in the ears or poor hearing. They can also have ear pain. And then blurred vision, diplopia. Weakness in the arms or legs, numbness, tingling, paresthesias, problems regulating temperature, tremors, heart palpitations. And a lot of the time, the heart palpitations are mistaken for panic attacks. Episodic nausea and vomiting is common as well. And then the symptoms as they present are a little bit dictated by the age of the patient. So babies, for example, may present with apnea. They may have hemodynamic instability, like a baby who is immediately or within a few hours after birth, having a dropping heart rate, low blood pressure, having to be resuscitated, and that can be Chiari. So the symptoms can be mild or they can be pretty catastrophic. Failure to thrive is common in children and infants. Poor feeding, delayed milestones. Around childhood into adulthood, we may see cranial nerve palsy, third nerve palsy, drooping of one eyelid or the other, poor coordination, hyperreflexia we see on examination, arthrogryposis, which is essentially a deformation of the fingers and joints. And you'll see how this is all related to EDS. Facial or upper extremity muscle atrophy. This is important in the sense that if you can imagine somebody with a sort of a blank face, a lot of the time, unfortunately, the patients are considered to have an abnormal affect or, some kind of psychiatric problem. And unfortunately, a lot of patients have been referred for psychiatric evaluation without having had an MRI. And it turns out, they look that way because of Chiari, because they've lost facial musculature and ability to even, smile or make normal facial expressions. So how do the EDS and Chiari come together? Well, there are a lot of symptoms that they have in common. Jaw pain, facial pain, temporomandibular joint disease. We see TMJ in EDS, but we also see facial pain with Chiari, neck pain, back pain. In EDS, the patients have problems with the joints, and of course that involves the neck and the entire spine. Aching in the arms and legs is common between the two. On the right, the slide is a patient of mine with Chiari malformation. She's had decompression. When she sits with her legs and feet down for any length of time, blood pools in her legs. She has poor vascular tone, which you can see between the two. Scoliosis. A lot of our teenage girls present for the first time without having had any symptoms of Chiari with progressive scoliosis, and then they're found to have that. The decreased motor tone that we see in EDS can actually lead to delayed motor milestones, delayed sitting, delayed walking, crawling, just as we see with Chiari. So treatment for Chiari malformation, if somebody is consistently symptomatic, if they're an adult, more symptomatic than they're not, or as a child, if you see signs of neurologic deficit along with symptoms, then we essentially treat with surgery, and that's the only definitive treatment for Chiari malformation. Surgery involves a suboccipital craniectomy, C1 laminectomy, and then, surgeons differ. Some open the dura, some don't. I always open the dura and expand it with a graft. So on the left, this patient has the Chiari malformation, tonsillar herniation down into the spine. And then post-op, she's had a suboccipital craniectomy, removing the bone here, opening the dura, removing C1. I did not remove C2 because it's more important for stability. And then I always remove the cerebellar tonsils, really shrink them and reduce them up so that they have more of a rounded appearance. And doing all of these maneuvers and then closing with a big graft to allow enough fluid around the brainstem and spinal cord and to decrease compression. And unfortunately, on this slide, I had a normal to compare. I think the next slide shows the normal picture. So this is a patient who actually had a Chiari 1 malformation with a syrinx. Fluid built up within the spinal cord, because the spinal cord is not, solid. It's not as soft as the brain, but it can act as a sponge, and when the flow of fluid is blocked between the head and the spine, the fluid has nowhere else to go, and it moves into the spinal cord and gets trapped there. So with decompression, this is a young girl who actually underwent decompression, and as you can see, after about 6 weeks, the syrinx had resolved. Usually we don't have to directly drain or shunt the syrinx if we decompress. This is her graft, and you see plenty of fluid around her brainstem and spinal cord. And also, with resecting the tonsils, opening everything up wide, the whole brain has lifted up because the global cerebral edema that was occurring has decreased. The fourth ventricle you see here is higher relative to the skull base. And even though she does have a little bit of a retroflexodontoid and decreased clival angle, she has fluid now between the brainstem and the spine. And unfortunately, it's not going to let us show the normal. So hopefully, if you are able to look at these slides later, we'll be able to correct this problem so you can see. But what we're really trying to do is recreate normal. So we're trying to recreate plenty of fluid around the brainstem and spinal cord, fluid buoying the cerebellum up so that there can be no slumping of the cerebellum, plenty of space between the graft and the brain, and fluid flowing out of the brain, out of the fourth ventricle, so there's no further blockage. Okay. And we'll have to move on with that one too, but that's just another child who has had a decompression, a Chiari decompression. Okay, good. So we hear, we talk a lot about Chiari, Ehlers-Danlos, and craniocervical instability, hereditary disorders of connective tissue, and do they predispose people to instability? And the answer is yes, to some degree. Patients with EDS are certainly more at risk for instability of all joints, including the spine. This is a paper by my colleagues Tom Millerat and Paolo Bolognesi from 2007. They were really the first to describe instability, hypermobility in the setting of Chiari with disorders of connective tissue. Now, every patient, this was really unfortunate. Oh, dear. Every patient with Ehlers-Danlos syndrome will not need a fusion or a stabilization procedure with Chiari decompression. But it just depends on, the clinical findings, the preoperative images. They tend to have disc bulges, disc herniations, and that's what I was actually showing on this slide. One of my patients who had had a Chiari decompression and had multi-level cervical disc herniations, which later she became symptomatic for, and she got the fusion that you see at the bottom, a 2-level fusion. This is a patient of one of my colleagues. This is a pretty old slide, but this is a patient of one of my colleagues who had a Chiari 1 malformation and was going to have decompression. As you can see, she has the tonsillar herniation here and what we call holochord Syringomyelia, which means pretty significant syrinx built up in the spinal cord. So she had the decompression, but then she came back for a follow-up, unable to swallow, choking, gagging on food and liquids, actually with one eyelid drooping, pupils were unequal, and she had weakness on one side of her body. And as you can see, she had a little bit of a retroflexed odontoid to begin with, and the syrinx, but now her syrinx is extended up into her brainstem and is larger than it was. She has significant collapse of the brainstem over the odontoid and pannus here. So she did require a fusion. She underwent transoral resection of the odontoid process, as well as a fusion. You don't see the hardware as well. You just see some artifact from it. And with stabilization, correction of her instability, her syrinx resolved. Again, didn't need to be separately drained. So what do we do as far as treatment of Ehlers-Danlos syndrome and Chiari malformation? Well, number one treatment, of course, is pain control for all of the symptoms. And the joint pain, as you know, can be very, very significant. Physical therapy, exercise regimens to strengthen the muscles to help stabilize the joint. We can't do anything to help the actual collagen problem, or depending on which type of Ehlers-Danlos it is, replace the proteins that work with the collagen to correct the disorder. But we can support the joint as best we can. Bracing and supports help, and then lifestyle and activity modifications. These patients certainly cannot do contact sports, football, wrestling. They should not do anything that predisposes to whiplash injury, definitely avoiding roller coasters, trampolines. Generally, we don't advise against athletic activity altogether, but and everyone is different. But if an activity, running, tennis, certain types of exercising leaves you with, joint pain for days to weeks afterwards, then that's not something that you can do. My patients with Chiari malformation who've had decompression, who sometimes have joint pain, neck pain, back pain, have actually found some relief with yoga. And that's counterintuitive if you have EDS because you're already hypermobile. So I think gentle yoga does help in terms of building up support for the joints. So here I had a nice slide showing the EDS awareness webpage with John Furman prominently featured, and information and support are the best. Our support groups for EDS, our support groups for Chiari, when you guys can get together and share information, that really, really helps. And so thank you for having me speak, and I'll be happy to answer any questions.
Thank you, Dr. Gilmer. We're going to go ahead and take you over to the Q&A section. If you can click on the icon up there on the top, it should be able to pull out the list of the questions that the live attendees are wanting to ask you tonight.
Okay. Can I read it out loud? Is that okay?
Yeah, go ahead and read and answer. Yes, thank you.
Okay. I just had surgery with me Wednesday the 24th, and today was a little rough walking. This morning I walked fine, but then at 11 when I went to walk, it was pain on my right side. I do have left side SI joint pain being treated with therapy. I have an orthopedic surgeon who knows about Chiari. Great. I instantly thought of a DVT and called my MIL, M-I-L. I'm not sure what that means. Mother-in-law. And if it got worse, I'd go in. I'm better now. I'm also off all my pain meds and only on Furacet and Robaxin and had my headache hat on. My headaches aren't bad, but when I turn my head, it hurts. But I know I have to do it. I was just scared on the walking. Okay, and she gives her name. Well, brain surgery, Chiari decompression, this was scary. And afterwards, the recovery, because as you saw from the slides, we split muscles that are, depending on the patient, anywhere from 2 to 4 inches thick. And all of those muscles go into pretty dense spasm. She's right. She does have to push moving and turning her head. and you can have these off and on kind of problems like weakness and numbness, but as long as they go away and they don't, last, then, we really treat symptomatically. You're doing all the right things. Okay, next question. Can burning feet be a symptom of Chiari? I have erythromelalgia and wonder if I should have investigation for Chiari. If the only symptom is burning feet, that would be unusual. I have patients who had burning and numbness, and certainly numbness and tingling in the feet is a very, very common symptom of Chiari. Burning is a sign of neurogenic pain, so nerve pain tends to be burning in character. If the only symptom is burning in the feet, then I would get an MRI of the lumbar spine. I would get an EMG and nerve conduction study, and also vascular studies of the lower extremities to make sure that it's not a circulation problem. If there are other symptoms, then I would ask for an MRI of the brain and entire spine looking for Chiari. Okay. Cheryl is asking, are people only born with Chiari? Does it develop later? Great question. Actually, both. I've seen both. We assume that people are born with Chiari malformation, but most of the time they only get images after they've had symptoms, right? They usually don't have a baseline study. That's why I really like it when the parents come with patients, no matter how old they are, because then I can ask about the birth history and whether they walked late and whether they were a clumsy child, whether they had troubles with swallowing, had to come home early from school all the time for headaches, and questions like that. And if those answers are all yes, then I know this person has probably had this since birth. But symptoms can develop later in life too, and nobody knows why. I think a lot of the time there's an accident, a fall, you stood up too fast, hit your head on the cabinet door in the kitchen, something that you don't even remember because you just keep going, doing what you were doing, but you develop a head injury, a mild head injury that leads to the symptoms coming out. I do have some patients who had MRI for whatever reason that did not show Chiari, and then later had studies that showed. So it also can develop later in life. Let's see. Cheryl would like to know if upright MRI rules out Chiari, but rules in craniocervical instability. Can Chiari later be formed? So if you have an upright MRI that shows no Chiari, but rules in craniocervical instability, I would say people interpret MRI differently. If there is craniocervical instability, which is causing later Chiari, I would say that perhaps it was a Chiari malformation that was more borderline, like a Chiari 0, or a Chiari with 2 or 3 millimeters of tonsillar herniation that the radiologist read as showing no Chiari, but in retrospect did show some at least low-lying tonsils. Now, we also have brain settling that occurs with basilar invagination, for example. And so, yes, if that progressed, then, the tonsils will sink further down into the spine. But that person did have Chiari. It's all part of the same problem. What do I think of interventional radiologists who don't believe in Chiari, who think it's only untreated CSF leak? Is it best to treat Chiari surgically? What is the best type of doc to diagnose? Well, EDS awareness, right? Chiari awareness. What we all want to do is increase awareness, and we get impatient with specialists who don't believe in a problem that people obviously have. That said, seriously, you have to be careful how you are spreading awareness. You want to spread information You want to tactfully ask questions. If you attack a specialist, why don't you know about this? Or, well, I think I have this. I think you're wrong. They're going to dig their heels in and be even more resistant. If you ask pertinent questions, well, is this possible? They might go and read about it, and they might know more for the next person. So what we want to do is try to be patient and increase awareness. Of course, Chiari is not only an untreated CSF leak. You know, nothing is all one way, only this, only that. You try to increase awareness when people are closed-minded, and if you can't, then you move on to the next person. The only definitive treatment for Chiari is surgical. Sometimes symptoms come and go over time. And again, you should only have surgery if the symptoms are constant, really interfering with your quality of life. Don't get better with taking, medications once or twice a week, and are really making you miserable. Now, it's different with children because children don't complain. So if a child has neurologic deficit and complaints of symptoms or not, and has a Chiari malformation, then I would decompress it. I wouldn't wait for it to get worse and worse because a child just isn't going to tell you that they're getting worse. The best type of doctor diagnose, actually a lot of the time our patients come from neurologists, pediatricians who suspect it and get an imaging study, and, of course, neurosurgeons. Any of those should be pretty familiar with Chiari malformation. Naomi is asking, is it possible to have this condition and not show symptoms until later in life? Absolutely. Absolutely. And that doesn't mean that it can't be Chiari. This is a problem with some practitioners who say this is something you've had since you were born, so it can't be causing your symptoms. Well, it can. And just because we can't explain why it wasn't symptomatic earlier doesn't mean that it's not. So, we look around for other causes. We check for Ehlers-Danlos. We check for other connective tissue disorders. We check and make sure that the symptoms are not, consistent with migraines or something else that can explain the symptoms. But if we don't find anything else, then it's the Chiari, and we go ahead and decompress the Chiari. Is there an association or relationship between Chiari 2 and EDS or other connective tissue disorders? Not that I know of. Not that I know of. That connection has not been drawn. Do you evaluate every patient for tethered cord syndrome, and if so, what are your beliefs on tethered cord release before decompression? Do you believe tethered cord release can alleviate symptoms and possibly prevent needing decompression? Also, can tethered cord release create cervical cranial instability? That's from Tiffany. Okay, I'll answer the last one. Tethered cord release can definitely not create craniocervical instability. I like to get a full spine MRI on every Chiari patient, but if I have a patient with Chiari 1 malformation on MRI and then I see tethered cord, I would still decompress the Chiari first and see whether the symptoms go away. And the reason for that is that the common symptoms of tethered cord, back pain, lower extremity pain, numbness and tingling in the legs and feet, neurogenic bowel and bladder, can also all be caused by Chiari. So you want to see whether decompressing the Chiari will cause resolution of all the symptoms. Now, if the symptoms are more suggestive of a tethered cord, then I will do the tethered cord first. But I don't do it to see whether I can make the Chiari malformation go up on its own, for example. In my practice, and we've looked at our cases, only about 8% of our patients actually had a tethered cord in association with Chiari malformation. So I don't just prophylactically release the tethered cord in every Chiari patient or anything like that. I really go by what the symptoms are. Let's see. Naomi says, I have several disc herniations. I've had 3 fusions in both lumbar and cervical. poor thing. So would my spinal surgeon have been able to catch this condition if I had it? Multiple disc herniations and with instability in the lumbar and cervical spine are a little suggestive of a connective tissue disorder, but it's not definite. 20% of people who have a problem in the cervical spine also have a problem in the lumbar spine and vice versa. It depends on whether it's degenerative. If you're very young and you had these problems, then it's certainly worth an evaluation for connective tissue disorder. But it doesn't say that you definitely had that. Are there lifestyle or activity modifications that people with Chiari 1 or EDS and or EDS can do rather than avoid doing to promote well-being? It's really more about being careful to avoid injury and recognizing that you're more at risk for injury. That said, most sources believe that exercise and increasing muscle tone and strength helps to stabilize the joints, and so that's something that you can actively do. What can be said about the correlation between tether cord and Chiari? I think I kind of answered that with the last question. What does the recovery of this surgery look like? My son, now 21, has Chiari 1 and had decompression surgery at age 1. He's done well overall. I suspect he may have a connective tissue disorder. He's not currently being followed by his neurosurgeon who retired. I'm wondering what type of doctor we should see to determine if he does have a connective tissue disorder. A geneticist. You should have him evaluated by a geneticist to see whether he has a connective tissue disorder. Rheumatology evaluation is good if you think that he might have fibromyalgia, for example, more of an inflammatory condition or autoimmune condition. But for EDS, it's a geneticist. Let's see. I'm doing my chaplaincy thesis on Arnold Chiari 1 malformation through the eyes of health, chronic pain, and spirituality. When my thesis is submitted, I'm turning it into a book for future medical doctors. What would you recommend I include? Well, I think, from the perspective of the patient, physicians have to really understand how miserable they can be, how much pain they can be, how wearing it is on a person to have a chronic illness, a chronic problem. The pain is multiplied when it never goes away. It becomes, just wearing on the soul. And I think we have to understand these are complicated patients, complex problems, so we have to have patience and try to understand what they're going through. How common is a slow return of physical symptoms following decompression surgery? I'm over 10 years out, and some of my symptoms are returning and worsening. Follow-up MRI showed reduced CSF flow, which the neurologist said would be expected. I would have her go and be evaluated by a neurosurgeon. It depends on what the symptoms are. What I've seen in patients, even if they aren't as far out as you, is if they are having continued neck pain, back pain, pain in the joints, that would be very suggestive of Ehlers-Danlos syndrome, and I would have them evaluated for that if they weren't evaluated before. If you have a return of symptoms, it's worth an evaluation. Where can I find studies on Arnold Chiari malformation type 1? Well, certainly, depending on how technical you want to get, the Journal of Neurosurgery, also the journal which is just entitled Neurosurgery. The NIH has more general information. Chiari awareness, certainly our support groups and our Chiari sites, Conquer Chiari, Chiari and Syringomyelia Foundation are both good ones. ASAP. Are there PT protocols known to help craniocervical instability? Actually, I don't think so. But the good news is neck pain with disc herniations and degenerative disease is so common in our society that most physical therapy places are familiar with exercises for neck strengthening and increasing range of motion, which will also help with EDS. The therapist just has to realize there might be some degree of instability and that you're trying to strengthen and build up the muscle to help support the spinal column. My 17-year-old daughter has been evaluated by a few neurosurgeons for Chiari. One said nope, but would not offer a reason for her symptoms. Another said yes. Okay, I'm sorry, I've got to stop there. So that's next. That really annoys me. I think we have a responsibility. If we don't believe that it's Chiari, to at least give you some direction, some guidance as far as what it might be. If we have no idea what else it is, then we need to have you seen by other consultants and other specialties who might. And if we really have no idea what it is, then we have to reconsider whether it's Chiari. Okay, that's my soapbox. Another said yes. She has a 5-millimeter herniation of the cerebellar tonsils, but it isn't the cause of her symptoms. Okay, again, why not? Anyway, her peds neuro had her fitted with a cervical collar. The symptoms are gone within about 10 minutes. However, the back of her neck starts swelling around C4 and goes down to about T3. Any pressure put on that causes her to pass out. Sadly, this is where the C-collar sits. So it sounds like she has abnormal circulation, maybe even abnormal vertebral artery circulation related to Chiari. And if you can visualize, the vertebral arteries go up the sides of the neck towards the back of the head into the back of the brain. And when there is stenosis in that area, there's also restriction on those vessels. And that's why sometimes people have numbness and tingling if they turn their head in a certain way. Some people pass out if they turn their head abruptly in a certain way because of that. So it sounds like the collar may be causing a little bit of constriction in terms of her blood vessels. Improving with a cervical collar doesn't mean she's unstable. I would get flexion extension x-rays on her, and if she doesn't have movement and if she doesn't have clear signs of instability on MRI, then I wouldn't assume it's that. I would assume that she just needs a decompression. Of course, I haven't seen her, so I would have to see her, to really be able to say that. Do you know of any EDS knowledgeable neurosurgeons in North Carolina? Let's see, who's in North Carolina? I think Mike Rausner's in North Carolina. Yeah, Mike is in North Carolina. That's who I can think of right now. What is the likelihood that my future child would get Chiari 1 malformation? 1 in 1,000. If you have Chiari, then it's more like 1 in 10. I would wait for your child to actually show symptoms. If they're if it's a baby, poor feeding, apnea, profound irritability, delayed motor milestones, in an older child complaining of headaches. And sometimes children have headaches, but if you can't point to not eating breakfast, not drinking enough water, not enough sleep, the usual things, and the child is having headaches that go on for, more than a couple of months, more than they are not having headaches, then they should have an MRI or a CT of the brain. What are the symptoms of tethered cord? This was mentioned in passing at an appointment years ago, but nothing further was discussed. Most common symptoms are back pain, pain into the legs, radiating down the legs, numbness and tingling in the feet, spasticity in the legs, problems with gait, and abnormal bowel and bladder. Abnormal bowel and bladder is sort of the least common denominator for tethered cord. All of the patients have some degree of abnormality, even if it's just chronic constipation or urinary frequency and urgency or hesitancy, like you really have to push before you can initiate a stream of urine, frequent bladder infections, leaking after urinating, kidney infections. In a child who has any sort of abnormalities of the kidneys or ureters, I would strongly suggest evaluation for tethered cord. How does a 4-millimeter herniation fall in the spectrum of Chiari malformation? Reasonable parties seem to disagree on whether this is a potential cause of neurologic symptoms or not. Well, first of all, the question is, would everyone agree it's 4 millimeters? Because a lot of the time the measurement is below the bottom of the skull. But if you recall one of the MRIs that I showed, in which the lip of the foramen magnum was a little bit thick, if you measured from the inner table of the skull versus under the bottom of the skull, you might get a centimeter in measurement. Assuming all of them are, measuring from the same place, we see patients sometimes very sick with 3 or 4 millimeter herniation. And then we can see patients with 20 millimeters who are incidentally discovered and don't have symptoms. So I think, unfortunately, evaluation for Chiari is something in which you can get 5 opinions, and they will all be different. And you just have to decide who you're most comfortable, which opinion you're most comfortable with, which seem to fit your particular situation, which seem to listen to you the best, and go with that. My daughter has RSD, developed POTS, and now diagnosed with EDS. No one has raised Chiari malformation, yet this sounds like you're talking about my daughter. How is Chiari diagnosed? MRI? Is RSD, POTS, and EDS connected? I have not seen RSD, which is regional sympathetic dystrophy, or also called reflex sympathetic dystrophy, or regional pain syndrome. I have not seen that in association with Chiari. That's more frequently associated with an injury to an extremity or a nerve entrapment. But certainly, if she has POTS and EDS, I would ask for an MRI of the brain and cervical spinal cord and see whether she has Chiari. Is basilar invagination related to Arnold Chiari 1? Yes, it is. Would the best place to approach the area be to go through the mouth to get to the brain stem? Oh, okay. That's a different problem. That is basilar invagination is a problem in which the brain and or brainstem are essentially sinking down into the spine. And there are varying degrees of severity of that. If a patient has it severely enough that they are experiencing cranial nerve problems, trouble with swallowing, choking, gagging on food or liquids, drooping of the face, problems with facial sensation, unequal pupils, then you would stabilize them by doing a fusion, but it's usually from the back, like the patient I showed who had slumped after Chiari decompression. We do a transoral resection of the odontoid when the odontoid process is retroflexed and actually impinging the brainstem. And that's a separate problem. Sometimes we have to do both. What is your take on Ehlers-Danlos syndrome in Chiari patients? And do you believe all Chiari patients have some type of connective tissue disorder? Well, it's certainly related. No, I don't think all patients have some type of connective tissue disorder, but it's certainly very common to have hypermobility in the Chiari patients, and that is not always a type of EDS, but it does warrant evaluation. Let's see. How do you change your surgical techniques when doing Chiari decompression in patients with EDS to prevent brain structures from falling into the space created by the decompression? There are several ways to avoid increasing instability. Your question kind of involves two separate problems. In my experience, if you don't go out too far, don't remove too much of C1, the first cervical lamina, and you don't touch C2, the chances of instability or worsening instability are small. Separately, as far as brain structures falling into the space, what you're creating is, am I able to go back to the slides at all to answer these questions?
Yes, you can just go back, click the arrow backwards. It should take you to the previous slides.
Okay. Let's see here. Okay, this is a good one. So what we're creating is open space, a large pouch of fluid to buoy the brain up. So it's not that you're creating a space for the brain to fall into, because remember, all of this space is filled with fluid, and that is what keeps the brain from sticking to the graft. That's what keeps the brain from sagging down or slumping. So you really don't have to do anything to keep it from falling in. You want the brain to be floating in fluid the way it's supposed to be, and that prevents a lot of the problems that we see. Okay, back to Q&A. All right. EDSers with neurologic symptoms must rely on clinical reports or the very sparse and often poor quality published findings on outcomes for craniocervical and instability, tethered cord, and Chiari-related surgeries. Are efforts underway among leading surgeons to publish their data? Yes, absolutely. Absolutely. There are some outcome studies. There was a good one by my friend Rick Boop down in Memphis, Tennessee, published earlier this year, and he looked at all the English literature on Chiari and outcomes over time. So that's a very large study. I think it involved 16,000 patients over something like 30 years. But you're right. I mean, we're very busy doing the surgeries and not necessarily writing as much as we'd like to, but we're trying to get it out there. I have a Tarlov cyst and a deep dimple at S2 to S3. I'm suspected by my PCP and neurologist of having tethered cord, but the tethered cord didn't show up on the MRI, just the Tarlov cyst. They also suspect I may have Chiari, but they believe the Tarlov cyst may be the cause of the symptoms that point to me having Chiari. I'm almost done with my treatment for a dislocated left jaw. My TMJ specialist recommended a few months ago that I see a neurosurgeon for C1-2 instability as well. With all this going on, what would you recommend should be taken care of first? Do you yourself operate on Tarlov cysts? Okay, yeah, you have a complex problem. Okay, first of all, the MRI is not probably going to show the tethered cord by classic criteria. Classic criteria of a tethered cord is a low-lying conus, almost, down to L3 or L4 with, maybe a big mass or something like that. With Chiari malformation, the tethered cord that we usually see is usually a tight phylum or a fatty, thickened phylum, which means that the phylum or the end of the spinal cord is thicker and wider than the surrounding nerve roots, and it really should be about the same or smaller. Those studies, an image like that is never, almost never, read by the radiologist as showing a tethered cord. So you want to show your MRI to a neurosurgeon who specializes in tethered cord surgeries and see whether they also say that it's normal. Now, separately, the Tarlov cyst. Tarlov cyst, yes, can cause a Chiari malformation. It depends on how big it is, and it depends on what your symptoms are. So you and your neurosurgeon can figure out whether this is a tiny Tarlov cyst and you have a large Chiari malformation that's not likely to be causing it, or whether it's a significant Tarlov cyst, it's surgically accessible, and it's reasonable to tie it off, get another MRI in 2 or 3 months, and see if the Chiari reverses. That has been reported in the literature. How likely would it be that a second decompression would be needed or even useful if the first was successful for a while? It depends. A neurosurgeon who specializes in Chiari will look at your MRI, and if there's anything that could be addressed, he or she will address it. So if it still looks tight, if it still looks like, maybe the tonsils are occluding the foramen magnum, or the brain is scarred to the graft, then they'll go ahead and explore it. If they really don't see anything that can be improved, then, we'll look elsewhere. Are there EDS symptoms that will emerge as a problem later in life? Is there benefit to obtaining a diagnosis earlier in life? Preventive measures that can be taken if the only current symptoms are hypermobile joints and skin. I'm not sure we quite know the answer to that. That's a question that can be answered by EDS patients who have had the diagnosis and been living with it for 20, 30, 40 years. But the knowledge is evolving about connective tissue disorders. They were just reclassified in 1997, which is really recent for, a medical problem. I would say trying to take care of the joints and avoiding injury as much as possible is the best thing you can do, trying to stay in good physical condition and avoid deconditioning of the muscles. Try to keep a strong core to take pressure off of the spine and the neck, and things like that. It's the best you can do. I am a 14-year-old teenager listening with my mom, and I have type 3 EDS. I have all the symptoms except problems with swallowing and rapid eye movement. My main problem with my headaches is having a buzzing noise in the back of my head when my head leans back. After my head goes back to a normal position, the buzzing noise is gone, but I'm lightheaded and I have a headache. I just got a laying on my back MRI, and the neurosurgeon didn't see a Chiari problem. Well, you might have another neurosurgeon evaluate it. Otherwise, we do see a lot of EDS patients with Chiari symptoms who don't have Chiari. So if, you have a couple of neurosurgeons evaluate your MRI and they agree that it truly is normal, then you have to treat the symptoms individually, and try to, and make sure that you're avoiding any sort of, destructive activities that might put you at risk for injury. I don't know if I mentioned it when I showed the EDS, the slide with all the types of EDS, but I have seen patients with Chiari malformation with every type of EDS except the last one, which was, type 6 is essentially extremely loose, sort of sagging skin. I have Chiari and Syringomyelia and had decompression surgery in 2009. My syrinx did not resolve, but it is stable. It is being monitored. My neurologist says that my ongoing symptoms, vertigo, nausea, are due to the flow of CSF in the syrinx, but says the syrinx is stable and there's nothing to worry about. Should I be worried when I get severe dizziness, vertigo, etc.? Well, I would make sure that you are seeing a neurosurgeon, and the neurosurgeon says there's nothing to be improved on as far as your decompression surgery. In other words, just because it's been done doesn't mean that you haven't scarred down again, you haven't grown back some of your bone. Adults usually don't grow back their bones, but they can't, and I've seen that. What happens more frequently is that scar tissue can evolve over years and cause some degree of obstruction so that you may have some flow, but not enough flow. It's a little concerning that the syrinx didn't go away. Sometimes it doesn't entirely go away. Sometimes it just decreases, like the slide that's currently showing. If you have only this much of a syrinx, then perhaps that is what we would want to monitor. If it still looks like this, I would really strongly urge you to get an opinion as to whether the decompression needs to be re-explored. Since I was blown off by my doctor for 10 years by when should I have my children checked if they are symptomatic? I wouldn't have them checked if they don't seem to have any symptoms at all. But, if they are having some abnormalities that you see and you know better than anyone else, you're their mom or their dad. Their mom. Okay, I see the name, Serena. You're their mom. You know them better than anyone else, so you should push for that. Also have numerous symptoms of EDS, but the rheumatologist I saw said didn't know anything about Chiari, and there are too many types of EDS. Well, you have, I was also told that my mom had Chiari. She passed away. I'm sorry. You should certainly be evaluated by a geneticist, and that will, I think, settle the question. I wouldn't worry about it until you have, the definitive answer. And of course, if you're still recovering from surgery, then it's very hard to flesh out which are symptoms of recovery, of the brainstem moving back into place, of the muscles, recovering and healing, and what might be a connective tissue problem. I was not symptomatic until a motor vehicle accident. I did not even suffer from headaches until the trauma. I have no images because I never needed an MRI. It is possible that I may have had the malformation and herniated at the time of trauma. Have you ever had a patient who was not symptomatic until trauma? Many. That's a common story. A lot of the time, because remember, a lot of patients with Chiari Malformation are asymptomatic and never even knew they had it until they have a fall or an accident and then become symptomatic. Generally speaking, what happens is that there's some brain swelling at the time of the trauma, maybe some bleeding around the base of the skull, and that results in scarring, and the person previously had some flow of fluid around the brainstem and spinal cord that then walls off with scar tissue, and then they become symptomatic. A lot of the time, even if there is some swelling that then resolves, the symptoms don't go away. So, no, that's very common. In your experience, what are the most helpful medications for decompressed Chiari patients with hypermobility EDS who are continually dealing with headaches, body, and spine pain? Gosh. A lot of the time the Chiari patients have some relief with Fioricet. It's a little bit strong. Sometimes they can have relief with Topomax, but sometimes Topomax makes it worse. Elavil is another good one. This is the arena where you need a good neurologist who specializes in headache management. I don't know of medication for EDS specifically other than pain medicine, anti-inflammatories for the joint pain. How many of your Chiari patients have returned for a second, third decompression surgery? None. Are there more successful decompressions or failed? Okay. I don't have any Chiari patients that I've had to reoperate on to repeat the decompression if I did the first decompression. I have done second and third decompression surgeries on patients who came, from outside facilities. I think that cauterizing and or resecting the cerebellar tonsils definitely helps. And now I was just at a pediatric neurosurgery meeting, and now about 70% of neurosurgeons who do Chiari decompressions at least shrink the tonsils. They just, and unfortunately, one of the slides that I couldn't show shows what happens sometimes if you don't resect the tonsils. The tonsils are still down in the spinal canal, still clearly occluding the flow of fluid, and it just wasn't quite good enough for that patient. Now that said, as most of you probably know who know Chiari malformation and familiar with Chiari surgery, there are many different ways to do a Chiari decompression. And the way I do it may be very different from the way others do it. Some people do a very, very minimal opening. Some people don't touch the tonsils. Some people never open the dura. They only decompress the bone. Everything works for somebody, right? Because if it didn't, we wouldn't do it. Nobody sets out to do an operation that isn't going to help. And if we did minimal procedures and people didn't get better, nobody would do them. But that said, what you really try to do is what will be the least risk for the patient and really minimize the chances that they'll have to come back and have more done. So that's my philosophy about that. As far as we know, the cerebellar tonsils have no function. That's the second part of Tiffany's question. And actually, when you're looking at a picture like the one that's on the screen, the preoperative image, when we open and look at the tonsils, they are usually white, ischemic. They haven't gotten blood flow. They've been, subject to long-standing compression, and they're really dead tissue already. If they can be safely resected in a piece, which you can't do if there are major blood vessels surrounding them, but if the anatomy is such that you can, and send them to pathology, the pathology report is always that this is dysmorphic tissue and ischemic tissue. So it's not normal brain that we're ever removing or shrinking. Okay. Do you know of any knowledgeable EDS Chiari neurosurgeon in Colorado? Oh, Dr. Oro used to be there, but from what I understand, he has retired. I would look at the academic centers in Colorado. I don't know specific names of practitioners there, but that's where I would look. I have occipital neuralgia, basilar invagination, cerebellum sag, Arnold Chiari 1, migraines, and cervical spine bulging disc. Doctors are saying that I need to be fused in my neck and take care of Arnold Chiari 1. They are saying that the surgery is very risky and high morbidity rate. They don't want to do the surgery until one of my neurofunctions default 100%. Okay. So we don't wait for something to default even 10%. You may have a problem that's high risk. Then that simply means that you need to see someone who has experience with doing high-risk surgery. But it doesn't mean that we're ever going to wait for you to deteriorate. Occipital neuralgia is a frequent sign of Chiari malformation because the occipital nerves are branches of the second cervical root, which is part of the upper cervical spine, and a lot of the time involved with the compression. Migraines, again, related. Basilar invagination is causing the cerebellum to sag because your whole head is sunk a little bit into your spine. So, it sounds like you need a decompression and possibly a fusion, and I would just find someone with experience in that. Will healing time, I lost this. Okay, will healing time of decompression surgery be extended with age and become harder with an EDS diagnosis? I have not seen that. The oldest patient I operated on for Chiari decompression was 74 years old, and she did great. I mean, really great. If someone has other problems, very overweight, such that the neck is very thick and there's a lot of tissue that has to heal, then that's a risk factor for poorer healing. Somebody who's sicker, somebody who's already in a wheelchair, somebody who's debilitated, somebody who's more severe, was already having significant problems with swallowing, weakness to the point that they lost musculature in their hands and arms, somebody who really was very, very symptomatic might have a harder time recovering. But everybody's different. I've seen patients that, 2 or 3 days after surgery, you couldn't even tell that anything had been done. And then I've seen patients who, 6 weeks out had to go to physical therapy because they're still very stiff in the neck and still having some pain. So it just all depends. If a Chiari surgery is performed, are there any activities or anything in life that the patient should never do after surgery? After the surgery, are they allowed, once completely healed, to do everything they were allowed to before? I know brain surgery is a big deal, and will the brain be more prone to injury after the Chiari surgery? Okay, so I answer the last of it first. No. If you have a Chiari malformation and you're symptomatic, then that means that you do have constriction and pressure on the brainstem or spinal cord. So you're actually more at risk before you've been decompressed, as far as, risk of whiplash injury, risk of paralysis or weakness on one side of the body after a fall or accident. Once the surgery's done, the person is decompressed, we really let you do anything except we don't recommend contact sports, so no football, no hockey, wrestling, boxing, bungee jumping, roller coasters are not a great idea. Now, I'm always asked about roller coasters. Let's address that. A lot of the time the kids ask, can they go on roller coasters afterwards? After you've been decompressed, you are more at risk for whiplash injury. That said, everything is a judgment call. I tell them they can go ahead and try a gentle one, not, something with a precipitous drop or, with a lot of sort of acute turns and angles. See how they do. And if they're doing okay, then that's something that they can do. I've never once in 20 years had a patient come back and say, I got on that roller coaster and I was terrible. So I think it's an individual choice. Is it common for patients to have Arnold-Chiari 1 and basal invagination? Yeah, we talked about that some. You mentioned sleep apnea as a symptom of Chiari in infants and children. Does sleep cycle dysregulation emerge as a complication of Chiari 1? My brother is 21 and had decompression for Chiari when he was 18 months old. He has done well overall, but has had problems falling and staying asleep throughout childhood, adolescence, and early adulthood, resulting in consistent sleep deprivation. Is this a problem that a neurosurgeon could address and follow up? Actually, sleep apnea is a very common symptom of Chiari malformation in adults as well. And a lot of the time the patients have disturbed sleep just because, they stop breathing, they wake up gasping for breath. A lot of the time they wake up frequently at night not realizing that that's why they woke up, but then they never get REM sleep. So they never really get rested, and I think that's related to the chronic fatigue that a lot of the time the patients have. Chronic sleep deprivation then causes a lot of other problems like problems with the immune system. So you have someone who's chronically ill, can't seem to fight off infections, mono and Epstein-Barr virus, colds, flu, sinuses, just chronically sick because they're never getting enough sleep. And that's not a small problem with Chiari. Are there any pain medications that work better than others? In my experience, NSAIDs work best for joint pain, Topamax for headache prevention, and opioids for muscle pain and current headaches. That's from Melissa, and that's great. That's a great contribution. That's what I've seen in my patients as well. Opioids can cause rebound headaches, so you have to be a little careful with that. But, pain control is very important. Unfortunately, my 17-year-old daughter's surgeon removed too much bone during decompression. What are the best options being developed for possibilities of cranioplasty that work better than options now which have a high failure rate? If we believe that too much bone was removed, then we usually will place a plate to give the cerebellum some support. But bear in mind, you're almost replicating the problem that you corrected by removing the bone. So you have to be careful about doing that. Well, that's generally what we would do if we really thought that had happened. Is the rare complication of cerebellar slumping, and I've only actually seen that about once or twice in my career, and that's what we would do, is put in a plate. You probably want to have her evaluated and make sure that there isn't something else in addition to too much bone removal that's causing her current problems. Please recommend a neurologist in Michigan who is knowledgeable in Chiari, tethered cord, and EDS. I understand a surgeon is who will actually help me, but I need someone to help with disability issues and communication with other doctors. Actually, if you call my office, 877-784-3667, we can give you some names for that. Good.
And we'll post her contact information on the same webpage that you used to log in tonight, which will also in a couple days have links to the recording of her presentation as well as a PDF file of her PowerPoint with those updated pictures, just so everybody's aware. And I think that was the last question.
Yes.
Wonderful. Okay, well, thank you for being patient with so many questions. You probably went through at least 40 questions for us. And
That's only one question per person.
Right, exactly. Well, I'm getting some feedback from the group who attended live tonight. And I just wanted to read a couple of comments to you because we appreciate your time and your expertise so much. And, I'm getting comments like your patient-centered perspective and expertise are so valuable, and you are absolutely wonderful and extremely compassionate. And also that your explanations are extremely helpful and easy to understand. So I second those comments and just really appreciate how you've invested in the Chiari and EDS community.
Thank you. Thank you very much.
And are there any last comments you would want to share with us before we close tonight?
I don't think so. I mean, you guys are very brave, very resourceful. I love how you support each other. You have to kind of see the 30,000-foot view a lot of the time, and that can be very hard when you're in the midst of the struggle and the frustration and feeling like nobody's listening. But hang in there. Hang in there. It's going to get better, and there are always, more resources. There's always, more hope. And there's always somebody out there that'll help you.
That's right. Thank you for being one of those. And we just wanted to close tonight and remind you that our next webinar is going to be on March 15th. That's 2 weeks from today. And this is for Ehlers-Danlos ring splints. A lot of people have problems with hypermobile fingers and thumbs, so we'll demystify some of that and give you some tools to use if you're in need of ring splints. And John, did you have anything else to add?
I just want to remind people that, yes, these programs are free, but we have to pay for them one way or the other, so we appreciate you going out to our store, bodysupportstore.com, where you'll find over 250 products that were selected by EDSers for EDSers. So we appreciate you go out and see the products that we offer. And we really appreciate Dr. Gilmer's presentation tonight. This is an area that is very interesting to many of our EDSers because we have the crossover. We're actually tied in with the CFF group, which is the Chiari Foundation. We do walks with them. They've been doing walks for the last 4 or 5 years, and we've now joined them, and we're doing walks with them as well. And we had a joint conference here in Cincinnati last year with the Chiari group. So we were collaborating with them, and it's a common goal to have more awareness and also to provide more education to our members and to our healthcare providers. So again,
and if you want more information, if you want more information about the Chiari Foundation, you can go to csfinfo.org. That's CSF as in cerebral spinal fluid info.org.
Great. Thank you very much.
Thanks everyone for joining us tonight.
Have a good evening. Thank you. Good night.
Good night, everyone.
Okay. I think that is it.
All guests have been unmuted.
His mom, he's got two.
All guests have been muted.